Hi, good afternoon, everyone. This is Liz Lazo from the AIDS Education and Training Center National Coordinating Resource Center. We welcome you to today's national webinar titled Models of Hepatitis C Care for People with Substance Use Disorders, Creating Treatment Champions. So today's presenters, Dr. Carolyn Chu, who is an associate professor in the Department of Family and Community Medicine, as well as the clinical director and associate director for the National Clinician Consultation Center housed at the University of California, San Francisco. Dr. Phil Baldick, who is the associate professor in the Department of Family Medicine and Community Health at the University of Massachusetts Medical School, as well as the associate medical director of special populations at the Family Health Center of Worcester, Inc., and is also the principal investigator of the New England AETC. Dr. Betty Dong, who is the professor of clinical pharmacy at the University of California, San Francisco School of Pharmacy, and Maggie Baser, who is the nurse practitioner director of HCV services at the Boston Healthcare for the Homeless program. Faculty disclosures, none of our presenters today have relevant financial relationships or affiliations with commercial interests to disclose. I will now go ahead and pass it on to Dr. Carolyn Chu.
Hi, thank you, Liz. So thank you, everyone, for joining today's call. I also want to thank my esteemed co-presenters. I really hope that this hour will be informative for all. So here we've got our learning objectives. I'm not going to read through them. There are many, but ultimately our overarching goal for today is really to encourage those of you who have not yet started treating Hep C to get really excited to do so, and then potentially for those of you who are already treating Hep C to possibly give you some new ideas of ways to reach other communities using some novel strategies. So this is quickly just a HCV care cascade. Those of you who might have been working in the HIV field, this will be somewhat familiar as we've got an HIV care cascade, and ultimately it's really just to provide a framework of sort of the discrete steps that are involved from screening and diagnosis through to getting people into treatment and curing them. And the reason I wanted to just sort of start out here is that we know that among various cohorts of patients who are substance use involved, and specifically people who inject drugs, there are very significant disparities in terms of where people are dropping off in our HCV care cascade. And so this is an incredibly important issue to be aware of and to think of how we can best serve these patient groups. So I'm just going to sort of start off by laying out an argument for why all of us should be really tuned in and energized to provide this service. And at this point, really, there have been many misperceptions that are floating out there. Stigma is a huge issue, not only for substance use, but also HCV and HIV. And I wanted to just start off by pointing everyone here to some resources that have been developed to try and specifically address some of these misperceptions. So this is just a quick snapshot of one of the new materials that have been developed from the AETC program. Certainly the AETC organization is not the only one. Harm Reduction Coalition is a national reaching organization as well that has really great material that's both provider-facing as well as patient-facing, and I would encourage everyone here to access those materials online, and we've got the website information down there on the bottom right. So this particular article I thought was really interesting to sort of pull out some quotes from, and I think, again, sort of breaking it out into two levels, patients have their own concerns about moving on to Hep C treatment, but I think it's really important that we understand what's going on, as providers. And the thought is that for many patients, it is a very real concern that they feel like some providers aren't actually attentive to their liver health or their hepatitis C needs. Here was a direct quote I pulled out from one of the patients that was interviewed for this particular study, and that person said, "Nobody's been monitoring my hepatitis C. They monitor everything but that. If I have a dirty urine, they monitor that before my liver or hepatitis." And so this is just echoing a sentiment I think that many of us have heard, is that some of our patients actually feel discouraged against pursuing treatment by their providers, including those who are managing their substance use. And I think for all of us, it's really important to know that this is an important conversation to have with patients. I think we want to make sure that we are doing our best to be open and encourage our patients to ask questions for all of their health concerns, not only what we might be focusing on just at hand then and there. I think it's also important to note that there are definitely some system-level challenges as far as access. So you'll hear later on from my co-presenters of some new ways that we can help improve access. I'm not going to spend a whole lot of time here, but I just wanted to highlight that we have now a great deal of data, both from clinical trials as well as real-world cohorts that have demonstrated unequivocally that Hep C treatment for people who inject drugs is highly effective. And I just have some names of the specific trials here. You'll be hearing a little bit more about the ANCHOR trial from Betty later on. And for those of you who might want some additional reading, last year there was an author group that published a really nice systematic review and meta-analysis, again, just highlighting the effectiveness of the current Hep C therapies in people who are substance use involved, and just the citation is there at the bottom right for those of you who are interested. So why is this really important? Well, a lot has actually changed over the last couple of years, and kudos to any of you who've been working in the advocacy and policy space. So from 2014, you can see there that a lot of states actually still had some fairly significant sobriety restrictions on approval for Hep C treatment. And in just a matter of a few years, that landscape has really changed. And I should point out that this is specific for Medicaid data. But if anyone here is on the call and you're in a state that has sort of the red or purple or darker hues, if you are interested, I would encourage you to link up with other stakeholders in your community to try and push for these to be lifted, because I think we really know that there's no evidence supporting these sobriety restrictions. So what is our call to action in the U.S.? So we are actually one of 4 countries across the globe that is responsible for about half of our Hep C HCV burden. And if we are going to be able to eliminate Hep C, we have got a ways to go, and we've certainly got patients who remain untreated. And I just wanted to, before I turn it over to Phil, leave everyone with this really striking sort of visual representation of what happened in Iceland. And so you can see in 2015, they really rolled out a very widespread initiative to treat everyone to prevent new infections. And you can see that in 3 years, they were able to make over an 80% reduction, specifically among people who are injecting drugs. Phil, I'll turn it over to you.
Phil, you are on mute. Please hit #6.
Great. Okay. Thank you, Carolyn. Thanks, Carolyn. So we're going to get started with the second part of this talk and look at a role that Hep C champions have played in eradicating Hep C at a country that set its sights really high, Australia. As you can see in the picture at the right, it's a huge country with most of its population spread out along the coasts. Unless we worry that Australia might not be a good example for us to study, a paper published last year reflected on the first year of their push for Hep C eradication and found many of the same challenges that we face with Hep C in the U.S., namely undiagnosed infections, infected persons having no symptoms and more pressing issues to deal with, providers long accustomed to seeing the impossibility of Hep C treatment for many and the long timetable until obvious clinical consequences, and the general stigma of the Hep C and injection drug use link that keeps many from seeking care. And these are all things that we're very familiar with. So patients and providers, sort of unconcerned, and stigma, very familiar. So in the Australian experience, they decided to break down some of the key barriers to Hep C treatment by making the DAAs freely available on the National Health Insurance Formulary and to begin encouraging general practitioners to prescribe DAAs. And so nurse practitioners, and they still have the term GPs, which are mainly family practitioners in this country. And in just a short amount of time, the percentage of DAAs prescribed from GPs increased from 8% to 31% in just a year after this push. And furthermore, they allowed direct-acting antivirals to be dispensed at community pharmacies and not just at specialty pharmacies. And in the first year, they were able to treat 19% of Hep C infected Australians, which is nearly 20 times the number of those who were treated in the first 20 years, or the prior 20 years. And their target is another 20,000 per year until 2030 to achieve eradication, which is very ambitious. So what are some of the key stakeholders saying about this experience? Well, as you might imagine, the first 20% might be the easiest 20%. The numbers are already starting to decline after the first publications about this. But they did say that primary health networks are the key to further success. And as you see here, this is not a map of Australia, it's the map of the United States. But if you look real closely, all those hundreds of lines there show federally qualified community health centers all across the U.S. And similarly to Australia, we feel that general practitioners are needed to start or improve comfort with Hep C treatment, and that the amount of training that's going to be necessary will vary greatly between practitioners. And really, point of care, just-in-time kind of support is essential for people to start feeling comfortable doing this. And also just as important is the use of multidisciplinary teams to help with patient registry tracking and keeping people retained in care and helping with prior authorizations. Also, one of the key lessons from the Australia experiment was to have multiple points of entry into treatment from both primary care clinics, substance abuse centers and syringe service programs, prisons and jails, and also hospitals. They talked about the critical role of local champions in promoting hepatitis C treatment, both to motivate action and challenge inaction among people who for too long have been able to say, oh, Hep C, it's not that urgent, it's going to take a long time, we'll focus on all the other things in the moment. And to approach challenges from within their own systems to help eradicate barriers to care. And you don't necessarily have to be as big of a pioneer and champion as Jackie Robinson was to make a difference with Hep C care. You can be champions in your own right to push for change and try to get your institution to get on board with treating Hep C. So let's look at the paradigm shift. Hep C treatment, in order to really bring down incidence and prevalence over time, really has to move from specialty to primary care settings. Champions who understand your setting-specific challenges at your local health center and who can provide professional development to their peers. That's really where the high impact is going to come in. So developing local champions. The other lessons from Australia were that champions should definitely include peers among persons who inject drugs to dispel myths and information about Hep C, to reduce Hep C stigma and discrimination, and help guide their peers through connections and trust in the medical system to getting on treatment. And there's significant evidence that supports the efficacy of using hepatitis C peers in this process. So I've mentioned the idea of hepatitis C champions, and the question is, who can be a Hep C champion? The reality in 2019 is that Hep C treatment is astoundingly simple compared to 10 years ago. And the biggest challenges in improving the Hep C care cascade are really existing outside of a strictly medical realm. Peers helping peers to trust the system and connect to care, and medical assistants prepping charts, noting who has been screened and things like that, talking about Hep C treatment to those who are positive, and RNs and LPNs providing education. All people with active Hep C infection should be linked to a practitioner who's prepared to manage comprehensive treatment. This is coming from the ASLD and IDSA website. And with the new potent and well-tolerated medications, all advanced practitioners and primary care physicians are encouraged to be trained in managing Hep C. And this comes from the specialty organizations, ASLD and IDSA. We really have their backing in treating Hep C right in the primary care medical home. There's no sort of turf battle going on where they want to retain all these patients. They know that there's way more than they can provide. They want to focus on the more complex and challenging patients. And so for the vast majority of Hep C patients who are fairly otherwise healthy, they should be treated in the medical home setting. So how are we going to find these Hep C champions? In a 2016 survey of family medicine residency directors, 78% said that Hep C is a significant problem for primary care, but only 62% said that their program should build Hep C treatment capacity. And very few are actually having treatment capacity already in place. And there's actually a pretty limited literature on the Hep C workforce development. There's a paper in the gastroenterology program about screening in primary care and Hep C training, but it's really not a big focus anymore in GI because they too are seeing that this is something that should happen in the medical home. And so if there's not really much existing in the primary care side, and if GI is starting to say, this is becoming more of something that should be done, outside of specialty clinics, we're in a little bit of an uh-oh situation around workforce development. And in fact, in a 2015 paper from Wisconsin, there was only one provider for every 340 Hep C patients, and 51 of 72 counties had no Hep C treating provider whatsoever. And I think that Wisconsin is probably not unusual if you were to do this study in other parts of the country. So in terms of finding and recruiting Hep C champions, we have to maybe think outside the box, and the VA has actually done that. They have this scope of practice certification program that allows prescribing Hep C medications from pharmacists, and this includes over 3,200 pharmacists nationwide in 41% of VA clinics. And so that's potentially one pipeline of Hep C treating providers that's hopefully will grow outside of the VA system. And in terms of developing champions in other disciplines, the workforce really has to be built within every part of the team. So from providers and pharmacists all the way down to nurses, medical assistants, peers, advocates, and public health officials, frankly, to help move the policy needle. You have to develop champions with the passion to care and make change for this population. That's really where it needs to start. And then use the available resources. There are incredible resources online to help people who want to develop the knowledge base. So there's a guidebook for Hep C skill building at the AIDS ATC website. There's an amazing Hep C self-study resource from the University of Washington. And the Hep C Guidelines website, which is jointly sponsored by IDSA and ASLD, is the definitive clinical decision-making reference, but it's also added a lot of content for people who are still learning the material. I was just using this today with a resident in clinic who is here doing a HIV and Hep C elective, and it's an incredibly powerful resource to use. And then when you really have a case that's stumping you and you need expert support live, there's always the National Clinician Consultation Center's live lines where you can get point-of-care support as you're calling in for some Hep C management advice. Finally, if you'd like to set up something that's more longitudinal with a mentoring relationship with someone in your region, the ATCs in your region can link you with local mentors for some care support. And now I'm going to pass it over to Maggie Beiser.
Hi, this is Maggie Beiser. I'm so incredibly pleased and honored to be able to participate today in the webinar. And I'm going to be sharing our experience at Boston Healthcare for the Homeless program in providing hepatitis C treatment in what I would sort of overarchingly consider a low threshold, high touch model. So we've started our program about 5 years ago. And to give you a sense, so Boston Healthcare for the Homeless program was founded in 1985, and we serve about 11,000 homeless and marginally housed patients a year. And we've had a high prevalence of Hep C for quite a long time, about 23%. And we also have a high prevalence of syndemic conditions, including HIV, substance use disorder, and behavioral health diagnoses. And almost half of our patients actually have behavioral health and substance use disorder. So our hepatitis C team really grew out of a primary care interest to addressing that within our care home, where our patients were well engaged, but they were not accessing specialty care even at the hospital across the street from us. And so we started with primary care providers, docs, and NPs, and built a team that is based really on the care coordinator and nurse as sort of the central aspect of the team. And our principles sort of overarchingly have been, we want to treat everybody and we have no sobriety requirement, but we're often trying to ascertain what the best time will be for someone to get treatment based on their sort of other potentially competing priorities or chaos in their life. Excuse me. To try to support people in whatever model they, or whatever relative stability they're in, we have a kind of blanket high-touch adherence support, which could mean weekly phone calls at the sort of least intensive, or daily observed therapy in sort of the most intensive in our clinic that's based among a lot of other services, including the syringe exchange, detoxes, shelters, jails, and residential treatment programs. On the right here, this is the algorithm that we've developed, and please don't get bogged down in the details now, but I wanted to point out that the color coding is meant to denote really sort of who is doing what job on our team, and to really highlight that the care coordinator in yellow is the single point of contact for any referral, whether it's a patient-generated referral or from a provider or an outside agency, and that all patients really get funneled through a preliminary assessment by a nurse who is doing updated labs and really an initial assessment of readiness. And then the clinician is doing a formal clinical recommendation, and then the prior authorization, the pharmacy navigation, adherence support, and on-treatment visits are usually handled by the nurse and the care coordinator. And that care coordinator, have a little bit enumerated more about the roles here, also does things like appointment escorting and as well as advocacy and participation in policy making. But that being that referral hub, that insurance expertise, pharmacy expertise person, as well as the adherence support person has been really fundamental to our success. I wanted to show you here, this is an example of our weekly tracking sheet, and this is an example of a patient who is very hard to reach throughout his treatment. So on the far right, I won't go through all of it, but this is a patient who took a week of treatment and was incarcerated, and then was released and took another 2 weeks of treatment, and then was incarcerated again. And we had to go through several steps to maintain his approval and restart him on medication. And he ultimately actually was cured. But this is obviously less than perfect situation, and he still did very well with a lot of high-touch involvement as well as motivation on his end. And that has allowed us to really scale up our capacity. So we start about 10 to 20 patients a month at this point, and we carry about 50 patients at a time on treatment. This is some outcome information from a study we recently published on the first 300 people that we treated. And I'd just like to point out that while we treated 300, we evaluated over 500, and a lot of people really did not end up initiating because they were lost to follow-up. So there may still be people who are not ready at this point in time, but we keep records on all of that, and we want to really try to get those folks back in whenever possible. But of the people who did start treatment, 95% were able to complete it, and 85% were ultimately cured. So even in a very chaotic situation in a primary care health home that's also doing a lot of substance use treatment, behavioral health integration, we were able to have a fair amount of success in treating our patients. Sorry, I'll hand it over to Betty. Thank you very much.
Hi, this is Betty, and thank you for the invitation to participate. I'm going to talk about some pharmacist-managed Hep C treatments, specifically in the Family Health Center where I practice and at the UCSF Liver Clinic. So one of the strategies for developing effective delivery models does require some understanding of treatment barriers. And although Dr. Chu has mentioned some of these previously, and that's identified in the last 3 bullets, in this small study of young people with injection drug use, a number of other feelings about lack of deserving treatment, as well as lack of illness acuity, actually were beliefs that reduced their ability to engage in care. So I think when we are developing models of care, we need to take these into consideration. So on this next slide are some of the principles and models for Hep C care, and we definitely need to shift the paradigm to optimize the Hep C cascade and make the patient the focus of the care. And in this era, DAAs are simple, effective, and curative, and as you've heard already, can be delivered effectively by trained non-specialists such as NPs or PAs or clinical pharmacists with comparable and sometimes better SVR outcomes. And we do have a number of resources that can support and provide consults for non-specialist trainers, such as our National Clinicians Consultation Hepatitis Line and Project ECHO that can provide specific consults. I think we need to meet patients and where they are, and so that means developing models that are convenient, accessible, and co-located and with multidisciplinary approaches
that allow us to bridge the gap between diagnosis and screening and linkage to care. Several studies suggest that co-localized care models, such as hand primary care clinics, opiate agonist therapy programs, in which Hep C therapy is provided alongside and at the same time where patients receive their care, have shown to overcome stigma as well as increase diagnosis, screening, and engagement. Likewise, dedicating resources such as peer navigators, telehealth, specialty pharmacists can actually facilitate care. And most importantly, we need to provide patient education to increase patient empowerment and reduce and offset any erroneous beliefs. So this is the model that may be helpful for all of our patients. So one model here that I'm talking about is pharmacist-managed programs, and there are a number of programs that have documented that clinically trained pharmacists with expanded care processes can provide excellent outcomes that are in the range of 95% SVR rates, as well as cost-saving benefits, improve adherence up to 95%, reduce provider clinic burden, and excellent patient-provider satisfaction. So I think this is one model that needs to be considered, and I've listed a number of studies here on pharmacist-managed programs. For pharmacists to have prescriptive authorities, one has to have a collaborative practice agreement, or CPAs, between pharmacists and prescribers that identifies what patient care services beyond the typical scope of practice can be provided. And these types of CPAs vary among states, and you would have to look at your legislation for what your state provides. Now, I want to talk a little bit about the ANCHOR program, because one of the most common questions about Hep C therapy that we get is how many tablets and how many bottles can patients miss and still achieve an SVR. This is the ANCHOR study, and this is preliminary data that was actually done at a harm reduction organization drop-in clinic in Washington, D.C., where they enrolled about 100 patients with injection drug use within the last 3 months. And they dispense Valsoft once a month for 12 weeks, and they looked at adherence assessments at week 4 viral load, which was a proxy for early adherence. If undetectable at that time, patients were likely to achieve an SVR. They also looked at interruptions and resumption of treatment, completion of study drug, and timing at 12 weeks. And I'm not going to go through all the data, but this data is very encouraging that supports giving DAAs to all injection drug users. And you can see here that patients who completed at least 2 bottles had about an 85% SVR per protocol. And one of the most impressive parts of this study was that 46% of patients completed after the 12 weeks, meaning they missed a pill here or there, and this had no significant impact on SVR. So I think the results show that imperfect adherence does not significantly impact SVR even with interruptions in therapy. And so in our clinics, we tend to say if there's less than 1 to 2 weeks interruption, that patients should be recommended to complete therapy without any effect on SVR. So these are some of the steps that pharmacists with advanced responsibilities can provide in your clinic. And there are 3 steps that I've outlined it here. One of the most important things is to start early, which means that it takes, depending on your lab, about 3 weeks to gather all the clinical data that one needs to evaluate the patient for any Hep B serology testing, complete a medication history for any drug interactions, and intervene if necessary. It is also an important time for the provider pharmacist to do an assessment of their patient motivation and adherence with medications and lab follow-up. And at submitting the prior authorization, it is key that there is some prior evaluation of motivation and adherence, which will be needed for approval of the PA. And lastly, in treatment initiation, it's important for patients to understand how to administer the drugs, either with or without food, manage drug interactions, anticipate transient side effects, and we often give them a schedule as to when they should do their follow-up testing and when their actual cure date happens. Drug interactions are very, very common. In this one study at the University of Colorado, generally patients, more than 50% of patients had interactions with vitamins, herbals, and acid reduction, and this happened in more than every patient that was seen. Recommendations are needed to mitigate and intervene with interactions. So this slide just summarized some of the acid reduction interactions, which tend to be much more significant with ledipasvir, valpatisvir, and the triple DAA, and not a problem with GP or elbasvir. In general, we try to ask our patients to stop any acid reduction therapy during the 8 to 12 weeks, and most patients are willing to do that in order to achieve an SVR. If not, then going to antacids or an H2 blocker is much more preferable. This is a great drug interaction website for you to look at before prescribing your DAAs. So one thing about accessing DAAs is a prior authorization is almost always required. And one of the most common reasons for denial is lack of sufficient information to assess medical need or medical necessity. It is really important to have the appropriate information to obtain your DA, and you can get a pharmacist to help navigate the system. It's important to also realize that the person at the other end approving the DAs or PAs are not always clinical, and that they're following a form, and that I've had rejections, but almost always rejections are approved by giving them additional information. So in some cases, you might get a rejection because the patient does not have any insurance. In that case, using manufacturer patient assistance programs are very helpful, although it may take several months to get approval. On the other hand, for patients that have very high copays, I've listed a number of patient advocacy programs, such as the PAN Foundation, which is the first one, that can actually help patients by approving copays for all medications. And so I think for most of our patients these days, there should be no reasons why they cannot actually get DAAs.
All right. So the next section here is considering special populations among persons who inject drug who are co-infected with Hep, or who are infected with Hep C. First, we'll talk about HIV co-infection. It's really all about managing drug interactions. Unlike the interferon-based treatments, DAAs don't rely on a patient's immune status, and so HIV Hep C co-infected treatment outcomes are equally fantastic. And you don't actually need to have an undetectable HIV viral load before initiating Hep C treatment. You don't want to put that up as another barrier to treating somebody for their Hep C. Interestingly, hepatitis C tends to have an immunomodulatory effect on Hep B, in which some cases of Hep B flares have been seen after Hep C was cured. And so you really want to check for Hep B co-infection before you start treating. And for people who do have co-infection, you want to monitor them closely for a potential flare both during and after Hep C treatment. You absolutely need to pay attention to a patient's opioid use disorder or other substance use disorders and co-manage that along at the same time with Hep C. And for a lot of people, that means medication-assisted treatment, but not necessarily everybody. This is a vital tool in retaining patients in care and improving overall outcomes. And really integrated MAT together with Hep C and primary care and behavioral care is the ideal model for success here. There are very few impacts of DAA medications on MAT meds unless your payers happen to be favoring the PROD regimen, which includes ritonavir, which really we haven't used now in a number of years. That may increase buprenorphine levels, but really nothing else has significant interactions with the medicines that we're using mostly now. And likewise, MAT meds do not really significantly impact the DAAs, so we're pretty clean in terms of drug interactions there. And then finally, in terms of mental illness, this is obviously a high concordance with hepatitis C and the behaviors that are often associated with it. So coordinating with mental health providers is really, really key because you want to make sure you check for drug interactions between Hep C and psych meds, and also just open lines of communication are always a good idea when you're trying to keep somebody retained in care and on medications at the same time that they're engaged in the mental health system. Turning now to Hep C and pregnancy, there's been an alarming increase in Hep C rates among pregnant women in the U.S., largely related to opioid use. In fact, there's been an 89% increase in Hep C among women at the time of delivery from 2009 to 2014. Overall, the perinatal Hep C transmission rate is between 4 to 7% in different studies. And unfortunately, DAAs are not currently FDA approved for use in pregnancy, but there was some data shown at CROI this year on DAAs in pregnancy, very limited. And so we're hopeful that over time we may have more evidence, mostly through most likely sort of unintended use during pregnancy, but like the antiretroviral pregnancy registry, hopefully enough experiential data will accrue, because it's not likely that we're going to get large clinical trials, unfortunately, looking at this in the near future. So hopefully we'll have a breakthrough on that, but I wouldn't hold your breath. In general, breastfeeding is still thought to be okay with women who are Hep C infected, and C-section really doesn't have a role in preventing mother-to-child transmission. The rate is so low, and C-section has not been proven to lower it any further. Women should avoid breastfeeding if their nipples are cracked or bleeding, but otherwise breastfeeding is not really a route for transmission. Really, this highlights that we need new treatment strategies for these women to help, most of all, help prevent Hep C before the woman gets pregnant, or treat it before she's pregnant, because right now we can't really treat during pregnancy. And so, you know, I really can't make any promises about Hep C treatment in pregnancy now, but that would be great. We really want to remember to screen Hep C exposed infants at or by 18 months with a Hep C antibody, because 4 to 7%, although it's not that common, it definitely happens when you're taking care of a lot of women, and we really want to know about these infected infants, you know, before a year has passed and trouble starts to happen. So I'm going to pass it over now to Carolyn for some final conclusions.
Great, thanks, Phil. So I know we've covered a lot of ground today, and ultimately, again, I think what we were trying to demonstrate is just that this work is really important. It can definitely be done, and we really would encourage you to find those treatment champions in your community if you're you know, wanting to increase access to treatment, and really put together some novel programs to treat people who might not otherwise access healthcare services in the traditional manners. So ultimately, we hope that we have convinced everyone that the DAA therapies are safe and highly effective among people with substance use disorders, and this does include people who inject drugs. We are, again, encouraging everyone here to find and develop and support Hep C champions in your community and within your organizations to make things happen. We heard from everyone, really, and I think particularly Maggie, that it's really important to make it easy for patients to get and to stay on treatment. I like the term that she used, which is really making it low threshold. So we don't want to make it such a burden or challenge for patients to be able to get treated, because a lot of patients will have competing demands. And ultimately, what we would love to do is to be able to really compress that Hep C care cascade from screening to diagnosis to counseling around treatment to getting meds approved and to cure. And I think ultimately the more that we can compress and sort of deliver wraparound care, early and support people through the cure, I think that will ultimately be sort of the most patient-centered approach that we can offer. Back to some of what Betty was mentioning is that, at this time, I think the DAAs are so highly effective that we actually don't totally have a clear picture of, what's that sweet spot in terms of adherence that might predict SVR. However, we do have some early and very promising data showing that brief periods of interrupted treatment do not seem to impact SVR, and I think at this point, certainly our group encourages providers to just try and, hold the course if they can. Obviously, we've got lots of point-of-care resources that you can turn to just for assistance to talk through cases, but ultimately, certainly any concerns about adherence should not preclude anyone from having that conversation with patients and getting them onto treatment. And again, here I think, Betty, as a pharmacist, I think has demonstrated that your clinical pharmacists can really be highly effective Hep C champions and partners. And the models of care are quite varied. It can be co-located in your practice. It can be reaching out to a community pharmacy to set up arrangements to help with the prior auth process and supporting patients. And so I think if any of you are practicing in areas that you might have pharmacists who are excited and willing to jump on board, I would encourage you to make those connections. So before we turn it over to Q&A, I just wanted to do a walkthrough of some of the resources. Phil had mentioned some of them already, but I'll just mention them again. So the Hep C guidelines, and you can see the URL there, this is sort of the standard of care, I would say, in the U.S. Again, it's put out by the Specialty Society, ASLD, IDSA. Betty had shown a screenshot of the Liverpool drug interaction checker, but there are actually a few more. So the University of Toronto also maintains a drug interaction resource online. And then for any of you who are treating patients who have co-occurring HIV and Hep C, the federal DHHS guidelines on Hep C treatment also have a dedicated table just looking at the antiretrovirals and the Hep C medications. For those of you who like to do some asynchronous or online sort of self-study at your own pace, or if you are perhaps involved with medical school or resident education, I would encourage you to take a walk through the University of Washington's Hep C web study. It is a phenomenal educational resource, and I just really cannot say enough good things about it, but it's just beautifully organized, really easy to use, it hits all the important points, and I would encourage those of you who don't know about it to bookmark it. As Phil mentioned earlier, the ATC also put out a national curriculum dedicated to increasing the visibility and sharing information about the care of patients who are HIV and Hep C co-infected, and you can see the URL there. One unique resource that I also wanted to share with this group, particularly those of you who are pharmacists, was that the CPNP, or the College of Psychiatric and Neurologic Pharmacists, have also put out a hepatitis C toolkit. And I believe this idea was born out of a pharmacist who had already been embedded in a mental health or psych practice. And this was sort of around the time that it was a lot of interferon for Hep C treatment, and just realized, pharmacists need to know, and they're also in a unique position. And so for those of you who might be working more closely in the mental health, psych, or substance use world, and want to have a pharmacist in there, this is a great toolkit that was developed just for pharmacists. The ATC program, again, thank you, Phil, for the shout out. Our NCCC maintains a number of free teleconsultation services. So we have a dedicated Hep C warm line. We also have an HIV warm line and a substance use warm line as well. Our hours are 6 a.m. to 5 p.m. Pacific, or 9 to 8 Eastern. And then the NCRC maintains a lot of wonderful patient and provider-facing resources, and I would encourage everyone to look through there. Betty mentioned the ECHO program. That is a really wonderful sort of way to collaborate and learn with other colleagues. Typically the ECHO sessions, there's a case discussion as well as a short didactic, and I think for providers who are interested and are able to schedule their patient sessions around ECHO, it can be really a high yield learning experience. And then for anyone who might be interested sort of on the advocacy front, Jason Grabely, who I believe is a Canadian but is in Australia, they put out, him and some co-authors put out recommendations for the management of Hep C among people who inject drugs, and this was actually in one of the drug policy journals, which I think is and I thought this article was a great read. Again, this is just a snapshot of one of the ATC developed resources that you can find online with the National Coordinating Resource Center. And more ATC developed resources here. I do want to call attention to the fact that all of these materials can be downloaded from online. However, there is a deadline coming up very soon, June 26th, if you wanted to order printed resources. And so take a quick look if you can, put in your order fast, because after June 26th, then CRC will no longer be able to print resources. So I think that, Liz, I'll turn it over to you. I know that a couple of really great questions have already come through on the chat box.
Yes, thank you. First of all, thank you all to our four speakers for that wonderful presentation. And I will open it up now to the questions in the panel discussion. We're going to start with two questions that came in the chat box. First from Ellie Coombs, and this one was during Dr. Bolduc's talk. Do you have any suggestions for state Medicaid programs that have lifted restrictions to encourage providers to prescribe DAAs, such as challenge inaction?
Yes, that's a great question, and I'll share with you a little bit of our personal experience here in Massachusetts. So after our Medicaid system called Mass Health lifted restrictions, our Department of Public Health decided to really try to promote this around the state. And so DPH and our New England AETC have been partnering to create Hep C communities of practice seminars, half-day seminars located in family health centers in Southeast Mass, and we hosted one here in Worcester. We did one out in the Berkshires. And with the explicit intention of inviting people both who are doing Hep C treatment together with those who want to do it, and we hold conferences that have just enough medical content to, sort of show people here's the scope of what you need to learn. It's not endless. It's not that intimidating, kind of unlock the black box, if you will, of what it is to treat Hep C. And then also sharing of best practices, letting people who are doing it share like a little bit about how they got things started to really kind of teach each other. And we've done this around the state, and DPH, our Department of Public Health, has really supported this effort by collaborating with the ATC around it. And so knowing, that there's support from not only these specialty societies, like I mentioned earlier in the talk, but also from your local Department of Public Health. Also, you can give examples of other health centers nearby that are doing it to convince your CEO or your medical director that, hey, this should be in our wheelhouse. If it's not, it's serving a need in our community that is really unmet. It kind of gives you the tools you need to make the case to do it because it's the right thing for patients in your community and for your mission. And also, frankly, financially, like a lot of health centers, FQHCs have embedded 330B pharmacies, and so if you are filling prescriptions on DAAs for Medicare patients, there's a significant revenue associated with that, and you can perhaps convince the financial side of things to say, hey, if we're going to be making this amount of money with some of the scripts we're going to be writing, we can pay for half time of an MA to help us manage our patient registry and not have to make it a financial ask as well as it sort of being the right thing to do. So I think that the nice thing about bringing people together is that different folks have learned different things along the way that they can share with each other that help problem solve and make it really, really practical. And I think that that's the key is trying to take people from like, oh, here's how you do it medically to here's how you actually make it happen in your clinic. And I've lost my connection to the Adobe page, so I can't see if anyone is writing in any comments to what I'm saying. I'll just sort of be quiet now, and Liz, maybe you can follow on to the next question or send me back if anyone has sent any follow-up comments on what I've just said.
No follow-up comments right now. I just want to remind everyone, because the lines are on mute, if you would like to ask a question on the phone, please unmute your line with #6 or go ahead and add in the chat box and we'll read it from the chat box. But I want to go on to the next question that was in the chat box again. Before we move on to the next question, I wanted to see if any of our other speakers had any comments on that question or would like to add anything.
Yeah, this is Carolyn. I'd actually like to add, and Phil, thank you so much for laying out all the sort of different options or ideas for people to consider. I mean, I think I would only add that in some ways I can't understate the impact I think that a Hep C cure can have also as a provider. I mean, the DAAs have really been revolutionary, and I don't really throw that term around widely, but it can be so gratifying, I think, to support a patient through treatment and to let them know that they've been cured. I feel like as medical providers, there's really not a lot out there that we can have that experience with, and it can be really revitalizing, I think. And, for those health centers that are able to, explore sort of sharing tasks, building out teams for Hep C treatment, in some ways for a provider, certainly if you can work in MA or RN or pharmacy visits, it almost decompresses what the provider schedule might, look like. And then ultimately, we know that Hep C has extrahepatic manifestations. And so we've had some amazing stories of people who get cured of their Hep C and, their pain is improved. Their mood is much better. They can think a lot clearer. And so for some patients, it's really been a huge change and a positive one in their lives. And I just think as providers, that's really nice to be able to, to share some of that success. And so I think that, I'm not trying to be sort of a Pollyanna, but it's real. And so, back to Ellie's question about ways that we can encourage providers to jump on board, I think those stories can really resonate. And I would encourage people to use those stories when they're trying to, enlist Hep C champions in their community.
Yeah, thank you, Carolyn. I can't say enough about how deeply satisfying it is to cure Hep C in people, because not only, like you said, all the extrahepatic manifestations of Hep C, there's a huge psychological burden that people carry with them. It's a daily reminder of their days of injecting drugs, and if they've been sober with MAT for a decade but they still have Hep C, they still in some ways feel dirty or burdened or reminded of that. And the weight that's lifted off of their shoulders when the Hep C is cured is really remarkable, and that's been some of the most satisfying moments that I've had in clinic over the last few years, is that moment when you can tell people that their Hep C is cured. It's really an amazingly powerful moment, and I think you're right that we need to share that messaging with people that this is a powerful and wonderful thing.
Great, thank you both. So I just want to move on to the next question in our chat box from Liz Wilson. Do milk duct infections impact breastfeeding transmission?
I think I'll answer that because it was in one of my slides around breastfeeding as a recommendation. And please, any of the other speakers can chime in if you know any more hard data about that. I'm not aware of any studies that have shown that is true, but it's kind of a common sense type recommendation more than anything else. So if someone, I think you'd probably want to help solve the problem for the woman first, and to play it safe you could pump and dump, but there is, to my knowledge, no data that's really looked at any sort of gradation of degrees of different levels of nipple injury and Hep C transmission, and whether or not a transmission rate would increase with that. I think it's more just sort of a make sense sort of recommendation. So you'd want to use your judgment there about how much sort of bleeding there is into the milk and the potential for transmission. So does anyone else have any comments about that on the panel?
Yeah, Phil, it's Carolyn and Betty. I think this is very much a data-free zone. I have not seen any studies, but with that said, I think that the entire sort of landscape of maternal Hep C care really, I would love to see that dial move quickly, because as you mentioned, we're just seeing a lot of Hep C among young women. And while we sort of wait for some more safety data to come out about treating during pregnancy, or just as you sort of mentioned earlier, women who might have already started Hep C treatment and then found out they were pregnant, this is a huge gray area. I think a lot of providers really don't know what to do. And even among the providers that have been treating Hep C, there's quite a wide variability in practice. And I think it does come down to really talking with the individual patient, framing this as a sort of risk-benefit conversation, knowing that there's a lot that we don't know as a medical community. And, to get back to this question about breastfeeding, I'm hoping that as we look more carefully at these issues, that breastfeeding will absolutely also just, be part of that conversation. But I agree, and I like your sort of common sense approach.
Yeah, and the other thing I would add, thank you, Carolyn, you put it more succinctly about a data-free zone, is that what woman who breastfeeds doesn't have cracked nipples, and so the fact that we haven't seen transmission yet from mother to child through breastfeeding means that I think the typical degree of chafing, chapping, cracking that women have that's not real serious with overt bleeding is probably going to be just fine, because otherwise we would have seen that there are transmissions happening, and that just hasn't been seen yet. So I think sort of using your clinical judgment about this is going to be fine for as far as we know it right now.
Great, thank you. I just want to open up, again, are there any other questions on the phone or in the chat box? And I do see that Dr. John Nelson's writing in the chat box, so he may have a question. To unmute yourself, you can press #6. I see there are a few people writing in the chat box. Actually, I believe I just unmuted all lines if you want to talk on the phone. So I know Dr. Nelson just wrote in the chat box, we do know that for women with HIV and HCV co-infection, they are significantly more likely to transmit HCV perinatally to baby.
Yeah, John, that's a great point. Thank you for bringing it up. I think there have been relatively few studies looking at this, but the data is there. And so this is very much not a data-free question, but I think it's about almost on the order of a 10 times increased risk. And again, so I think it just, we should all be encouraged to, for anyone caring for people who are co-infected, just to know that there are these additional layers to keep an eye out for. Thanks for bringing it up, John.
We do have an additional question I want to get to before the end of the webinar from Denora. Can Hep C be equally cured among young and old patients? And is that specifically, Denora, for any particular speaker, or would any of the speakers like to address that question?
Yeah, I mean, this is Betty. I'm not sure. Are you talking about pediatric and geriatric patients? At this point, some of the medications, the DAAs, are approved for pediatric patients, and
I'm sorry, I believe there's some background noise. All lines are open now, so please put your phone on mute. We do hear someone talking. Go ahead, Dr. Dong. I apologize.
Yeah, I was saying that they're just recently the DAAs have been approved for pediatric patients. I haven't personally treated any young patients at this point, but we have in our clinic treated young patients in their 20s and older patients, geriatric patients, and there have not been any age factors that have made a difference in cure rate. Of course, patients that have more cirrhosis, especially decompensated cirrhosis, may be much more difficult to cure since the regimens are a little bit more complicated. But at this point, there's no data that says that there's any difference in cure rates between young and old patients. And that the data in pediatrics that led to approval showed comparable SVR rates.
Great, thank you. So we are coming up to the hour, and I just want to ensure if there are any other questions, you can send them over to me, and I will go ahead and get them to our speakers to get you the answer. We would like to thank everyone for participating on today's webinar. Again, thank you to the 4 speakers And just want to say thank you to everyone. We will post this as a resource on the NCRC website. Thank you and have a wonderful day.